this recording now. So thank you all so much for taking the time to be with us today on our discussion of the topic of how to increase resilience in health systems infrastructure. The Brown Bag series is a new offering for sharing ideas and innovation from the Florida Institute of Built Environment Resilience, or FIBER, as it's more widely known, and was the brainchild of my colleague, Dr. Von Medic, who is on this call as well. And this is really the first forward external facing one of these that we've had. For those of you who are on the call and who aren't familiar with FIBER, FIBER is a research institute that was established in 2018 at the University of Florida as a strategic initiative with the College of Design, Construction, and Planning. With support from UF's Provost and Vice President for Research. And the mission of FIBER is we're committed to doing research on the design, planning, and construction and management of resilient built environments. So I'm Lisa Platt. I am a researcher and your host today for our panel discussion. And we have a just amazing team of experts with us here today who have been willing to come and talk to us about the topic of resilience in the built environment. So as a way of introducing them, the first person on our panel is Brad Pollett. Brad is the Vice President in Facilities of UF Shands Hospital, and Mr. Pollett's professional experience includes oversight of $1 billion in hospital construction and management, and about 6 million square feet of hospital facilities and environment of care. He oversaw one of the first LEED certified cancer care environments that Shands is very proud of, and legitimately so. And he also serves as an expert on the FIBER's advisory board and is a great asset to us. Kim Shin is a principal sustainability wizard, which I think is probably the coolest job title ever, with TLC Engineering Solutions. And his primary area of expertise as it relates to built environment resilience is serving as an expert for USGBC lead healthcare steering committees. Kim's passion for sustainability led him to become a lead AP in 2001, and he was elevated to a lead fellow in 2011, which is a pretty unique standing. And he was part of the inaugural class of fellows and given U.S. Green Building Council Leadership Award in 2020. Dr. Lisa LaRusso is the Healthcare Director of Research and Insights at Gresham Smith. She's also a UF graduate. Her role is to strengthen healthcare planning and design firm-wide through human-centered and evidence-based design research. And finally, Lauren Sadowitz. Lauren, am I saying your last name correctly?
Yes, you are.
Okay, great, thank you. Lauren is an environmental scientist experienced in organizational level resiliency and leads Gresham Smith Sustainability and Resilience Center. So I'm going to stop sharing my screen because I'd rather have you see our panelists than see my slides. So I'm going to start off our question and answer session with some prepared questions. However, we're also welcoming questions from our attendees. So if you have questions, please, during the question and answer session, feel free to type them into the chat or just raise your hand. And my co-host today, Arazu Zanali, who's one of our FIBER graduate research assistants, is going to be watching the chat box for those questions to come in. So to begin with, I'm going to ask by asking our panelists, and you can answer in any order you like. How do you individually characterize the property of resilience as it relates to health systems? And anybody can go in any order they wish.
All right, well, I will take that. Thank you, Lisa. So, from our perspective, we work with all clients across the board in different markets. Multidisciplinary firm is our focus area, Gresham Smith. And honestly, it's all about, boils down to what are the minimum needs in order to keep the doors open during and immediately after a disruption. And then what is the acceptable recovery time and cost to do so? And so for many of our healthcare systems that we're working with, honestly, what we've heard, and we've done an informal, we'll call it an informal survey with some of our clients most recently, cybersecurity is top of mind for them. And, that the implications of that, of course, are widespread, extends beyond just being able to access medical records, but also to the equipment and building system functions as more and more access controls are moved to the cloud. So really in that digital era, operational data has really become a critical asset. And then from a physical infrastructure perspective, we've been really looking at this from a holistic perspective. We approach that holistically, looking at your critical systems such as power and water and sewer, access to your facility, the supply chain, and then, looking for opportunities from a resiliency perspective for all of those. Are there opportunities for redundancies such as dual power feeds? You have warehouse of supplies. Even on the people side, do you have MOUs that are established with your area providers to supplement areas that you may have some gaps? Additionally, what can be fortified? On the looking at floodgates, protecting against high wind, reinforcing the internal building structure and envelope, and then what can be flexible, what is flexible, and what can be moved. So those are some of the areas that we're looking at and hearing about from categorizing what is a resilience, the properties of a resilient structure.
Great, thank you for that, Lauren. Brad, Kim, Lisa, any of you want to field the question?
Sure, I'll give a simple answer. The ability to meet a risk-assessed response plan. And the reason I say that is there are some things that we're gonna see, and we expect to ride through them and be operational. There are some things that we are gonna see, and we expect to modify our operations to adapt. And there are some things that you're just gonna walk away from, and you need to have all of those plans. So it's pretty broad, but every hospital has some level of risk assessment that they've done, and it probably should go to the top events they think they might see. And then each of those should be looked at, and they should have a plan, at least an outline of a plan of how they're going to manage that going forward.
Yeah, and I'll just add a little bit to riff off of what Brad and Lauren said. With our clients, resiliency means a lot of different things. And so the property of resilience in healthcare systems, it could be materiality on the design side, really looking for a lot of flexibility, durability, those sorts of things for the unprecedented, situations of the future, for what's coming next, going beyond codes and trying to see into the future, but then also building in redundancies, right? So fortifying, strengthening, the infrastructure itself, and then providing something that's flexible and can adapt. So.
Great. Kim, do you want to field the question?
The great thing about waiting for everybody else to talk is they've already covered everything.
Okay, good. Well, good. I'm glad we got a comprehensive response. So I'm gonna jump ahead on the questions that I had prepared based on Brad's response and talk about the elephant in the room, which is, has the current pandemic changed the way you approach your response to both known and unknown risks and adaptive capacity and planning for operations of healthcare environments, both from inside the healthcare environments or as a planner for healthcare environments?
I'll go first. So yes, we have looked at how we've studied the systems that were impacted by us with the pandemic. A lot of things have been learned. especially if you look back. So one of the things that we've learned is that communities need to be responsible for surge, as an example. So when you start thinking about the health system, you need to think broadly. It's not just about a hospital or a set of clinics. So communities need to be prepared to take on massive surges of patients, because the hospital, even if they have the space, they don't have the staff. Okay, so it's not just a building. It takes people to take care of people, not buildings. They don't take care of anybody. We have found that adaptability within the facility, having enough flexibility so that people can change their operations to meet the input that they have to address was very important. I mean, it was easy enough to transport patients through a hospital. You can put a mask on them and move them where they need to go. You don't have to have isolated entrances or anything like that. But if you're caring for people in the hallway, then you have an area that this wasn't going to be able to accomplish what you needed to have done. There's some things like infrastructure components. I think everybody would probably, if you talk to operators now, they would say, don't discount our oxygen lines as an example. So normally you provide some level of discount so that as you collapse these into branch lines, you have the ability to make them a little bit smaller, because you never count on all of them being used at the same time, unless you have this pandemic. So, I think people are looking at it and saying, it's pennies on the dollar to keep the line full size and make sure you can cover that. I think people would probably say, I'm not going to try and HEPA filter everything, but why not put room in the racks so that I could add HEPA filters to an air handler? Would allow you to do that. I don't need to bring in fresh air. I need to clean the air I have. So those are some simple things that I think you start to see showing up in building design in order to deal with that. There's others, but I'm sure other people have seen some of those too.
Kim, I know that's an area of expertise for you, especially HVAC and sustainable energy efficiency and IAQ for the healthcare environments. I'm curious to get your perspective on that too, in terms of, do you see the pandemic being a catalyst for approaching the design for building systems in any way that was different than you thought of before?
That's a really interesting question. And if you had asked me that question 18 months ago, my response would be entirely different. One of the things that I was really struck by as we move through learning more and more about this particular disease is that our North American healthcare system is remarkably resilient in terms of infection control from the built environment standpoint. And I have to give credit to Brad for bringing out this idea of, it's not buildings that take care of people, it's people that take care of people. And the community part of that, I think, has been grossly underestimated. And for whatever reason, we were taking public health for granted before this happened. But going back to the physical environment that we have to maintain through the codes and life safety things that are part of the healthcare environment have served us very, very well. If it wasn't for the fact that hospitals were just full of sick people, they would be the safest places to ride out something like an airborne infection disease. And we very quickly learned that we didn't have to modify huge numbers of our systems to handle that. That if we had just taken a beat back in March of 2020 and said, don't panic, the Hitchhiker's Guide to the Galaxy, don't panic. We would have seen that we really had the ability in the infrastructure built environment that we had to handle a much more profound and infectious disease than even this one. And I also have to give credit to Brad for pointing out that from a sustainability and resource conservation standpoint, we can do things to manage the infection control environment that don't have a profound effect on energy use or resource use. If we had just stepped back and taken a beat before we just, some folks, and I have to say that in an abundance of caution, they did things that really didn't need to be done. And if they had just thought about how the disease moves around in the air, and we didn't really know that to begin with. But what we know now is that we've got a pretty resilient, at least from an infection control standpoint, built environment in North America.
It's good. I love the Hitchhiker's Guide to the Galaxy reference too. It's one of my faves. What about you, Lisa? Yeah.
Put out a tiny bit just to say, about the recent collaboration we did with the UF Interior Design Studios, really encouraging the students to think about how do you plan for surge capacity. So, working with the upcoming, workforce and getting them to already think about, what sort of things can you do, in the planning stages to think about, and it's not necessarily always a pandemic, right? It could be a mass casualty. It could be in Florida, it could be hurricanes or natural disasters. And so getting that really top of mind in the sort of programming, really early schematic design phase is really important. And that was a lot of fun for our design teams to participate with the UF studio and see what the students did. But they were really creative about solutions where they had charging stations in the parking lot that then could also have walls be brought in and be turned into sort of a pop-up triage centers. And they worked with the UF Health North campus map when they were doing that project. But just as designers thinking about that step and getting that rolled into just our design process is really important.
That's great. What about you, Lauren? Do you have anything to add to that?
I do, and all of this kind of feeds up to I do a lot of planning work with our different project teams and our clients. And honestly, the pandemic has allowed us to have more open conversations about what are your goals when you're looking 50, 75, 100 years from now. We're going to be helping with designing and constructing a new facility for you and thinking about the lifespan of that facility and what is it going to be facing during that lifespan. There's a lot that goes into it. And, I think what's been said, on the people side is really important. And then just taking that information, this pandemic has allowed us to have that, open the door for larger conversations that take us down roads of, oh, well, I don't know how long I might need to operate off the grid. That passive survivability. Yes, I do need to shelter in place. I loved your point there, Kim, of, really it is one of the safest places. Hospitals really are. I mean, you have so many measures and controls in place. It really is. And then we also saw this as well, just because you're in one crisis doesn't mean you're not going to potentially get another. And so you get a hurricane or an earthquake or a fire during a pandemic. Okay, well, now you're working 2 fronts or 3 fronts. And what does that look like? And being prepared on the infrastructure side for those. And it takes an entire team to really come together, and the owner is really critical to helping to have that vision to say, okay, yeah, I see right now that, we might be tight in some resource areas, but, we have room to grow. We can expand. We can, if there's going to be a heat waves in the future, we're going to be having those higher heat degree days, that we can, we're putting into place right now distribution systems that can handle additional capacity, and just thinking that through of what's easier to change now versus something that you can grow into.
Lauren, it makes me think about the Bucket Brigades. Did you want to say something quickly about that with our Northwest Florida client?
Sure. Yeah, that's a great point. So one, we were recently working with a client up in Northwest Florida, and they had an outage. They lost potable water, and the only way to get water to upper floors to flush toilets and other uses is through bucket brigades. and thinking about the impact of that, taking staff away from other critical needs, responding in the crisis, in the moment, to move water by one bucket at a time, is disruptive. It continues that disruption further along, and being able to account for that. And there may be there could be multiple measures in which to do so, and that's what we have worked through in our design, so that does not have to happen again, and making those conscious choices as we go. Go ahead, Ken.
One of the things that sort of came out of this pandemic was a proliferation of magic solutions. What's the gizmo that I can buy and plug in or do differently that will fix all of this? And almost without exception, it's all BS.
Thank you.
And I may actually ruffle some feathers here, but antimicrobials are a bad idea. They are a way to thin out the weaker bugs and make sure that the stronger bugs can proliferate. And anything that can kill a microbe can potentially harm a human cell. I mean, if it's bad enough to disrupt the DNA of a microbe, it's bad enough to disrupt the DNA of a human cell. So really, once again, take a beat, step back. If it's too good to be true, it probably is. Rely on the things that have a proven track record. Don't get completely off the reservation trying to come up with that magic bullet. There's very few of those around.
I tell peer organizations to follow the science. Even if it lags a little bit, wait and follow the science, because UV light in your ductwork isn't going to kill anything at 550 feet per minute. It just doesn't have enough exposure time. So
good advice. I think we've all seen commercials for endocrine system disruptors being sprayed on doorknobs and cringed a little bit. So but anyway, I want to circle back on my next question, because it's something that Brad and Kim touched on in terms of people taking care of people, not building taking care of people. And Lauren and Lisa had talked about, how do you plan for the unknown, and knowing that we have several complex climatic factors and public health factors on the horizon. Some we know about, some we don't know about. So what do you see as a fundamental way, perhaps right now, that healthcare infrastructure can support public health resilience in a way that might not necessarily be happening to its optimal ability?
in a word, access. We need broadband. We need access for community health. I mean, how much of our community doesn't have healthcare at all? So forget being able to manage normal chronic or subchronic diseases. A pandemic shows up. We know now a lot of things could have been dealt with at home. But if you don't have internet, you don't have a way to get in to see your doctor, you don't have a doctor to get to without access. If you want to change the face of public health, get access to health for people.
Yeah, Kim.
Brad may take away all of the thumbs up he gave me in the previous question. In terms of public health, the North American healthcare system is a resource pig. And the way, well, thank you. There are many things that our industry, the healthcare industry, can do to decrease its resource intensity in terms of solid waste production, in terms of energy use, in terms of the carbon emissions that are associated with energy use. And those have a profound effect on both global health and local health. I think our healthcare industry needs to take a much better citizenship standpoint in terms of how it impacts the environment. You know, when we talk about resilience, we talk about being resilient against climate change. And there are very few industries in North America who have a greater energy intensity than healthcare. And that, if, you know, first do no harm, we could really take a step away from doing the harm that we cause in terms of climate change.
Yeah, Lisa, did you have something?
Yeah, so I would say from the design process perspective, co-design is key, right? And so, you know, we actually, our team published a paper in the Herd Journal earlier this year just about what co-design really means. And it's really putting, early on in the design process, having this collaborative team of, you know, designers, the design firm, their, you know, cohorts and engineering and any other consultants, but the client themselves, but the community as well. And so really setting up this collaborative team in the very beginning stages, you know, doing, some of our teams do learning labs, community engagement issues really early on to really try to gather that qualitative input from the community that the hospital will be in, right? To really learn what's the culture, what are the needs, what are the deficits right now where this facility either is or is going to be, and making sure that that is fully integrated throughout the design process. You know, and it's great because you have these, Kaiser calls them super users, but you have these champions that sort of get baked into the process that come from, you know, the community aspect, the client aspect, and the design team. And, you know, the end result is much more resilient as a, you know, it's the natural product of having that more collaborative co-design sort of process that looks at human-centered design, right, and integrates evidence-based design. So really looking at, like Brad said, you know, follow the evidence, look at the science. So really not just falling into best practices within design, but looking at evidence-based design and how that folds into, you know, what's being pulled through. So that is one of the things that we've seen has been really key to, you know, healthcare infrastructure supporting public health and the resilience.
Lauren, did you have anything you wanted to add?
Honestly, I agree with my the other panelists on this one. I think, you know, it really is about that community perspective and being able to engage further with them in the different ways that were already mentioned. So support you all.
So I want to take a beat here because we have several people on the call. I know a lot of us in fibers research focuses on things like social equity, resource balancing, improved access to healthcare, and certainly the digital divide that Brad mentioned. So I want to just, you should be able to unmute yourself now or type into the chat if you have any questions for the panel that you'd like to ask at this time.
While they're typing, I'll add on to,
Sure.
Kim was right on. In America, USA, we don't have a healthcare system. We have a healthcare industry. And one of the problems with that industry is that if you've been to a hospital, you've been to a hospital. And because the people in charge there went to a school, and that's where they learned, and that's what they brought. And so everything is unique. And we don't learn well from, you know, there's probably 5 emergency room designs out there that would meet most all of the emergency room needs if people would learn how to run a process consistently and across the board. There's probably 5 best processes. There's probably 5 best nursing units. And yet every time we go to design a hospital, it's a whole brand new endeavor from the ground up. And so you lose, it comes down to the people right there, and you lose their, all you get is their individualism, and you lose the knowledge that might've been shared across the board, you know, in a broader context, and the best practices.
So as people are still thinking about what they want to ask, I'm going to dovetail off of your response, Brad, because I think it raises a really interesting point in terms of leveraging best practices that might not necessarily be as transparent and easy to connect as they perhaps could be. So what other types of, other than the pandemic, which we know has been a kind of sea change in terms of people's perspectives of how to approach healthcare planning and operations, what other kind of response measures, whether they be disaster related that are emergent or happening right now, do you feel are critical for planning healthcare infrastructure, either through leveraging good practices that are already happening right now, or predicting ways to perhaps respond to emerging crises that might be on the horizon?
One of the first things that I'll just go quickly first is staff resilience, right? And so, finding ways within the built environment to, help mediate staff burnout and turnover. How are we, on the disaster response side, sometimes it's, what are the needs of the staff if they are, do you need to have showers or certain accommodations for people if they are ending up living in the hospital for a certain amount of time, right, in a surge situation. But just thinking hard about how can the design of the facility address resiliency, restorative breaks for staff, those sorts of things.
Yeah, and adding on to that, so disaster response, of course, is required that healthcare facilities have an emergency response plan, and that you have that day one, you open the doors, you have thought these thoughts before, but expanding from that's on the operational side, and I know I alluded to it a little bit earlier, but on the changing climate conditions is another aspect that is top of mind for many of our clients that we're seeing. Extreme weather events are becoming more frequent and intense, and it really, someone had mentioned this, and I took it to heart. If you really need to have, hospital systems are your safe havens, and you need them most when in the middle of a crisis. So even if you're not able to access them at that moment in time during the crisis, you're going to want to get there as quickly as you can soon after. And so making sure that you can get back online in whatever capacity that is possible at that time to do so. But that takes a lot of planning. There's a lot that goes into it, and being able to get all those resources lined up appropriately, and then you feel prepared, and but you limit that impact and the cost of it that you're trying to mitigate to go forward as well. You're serving, you have your different spheres of your community that you're trying to support. Some populations that you're going to have to go out to versus them coming to you. What are all the measures in place that you have in order to reach them in those time of needs? So all of that upfront planning, yes, just building on your existing emergency plan, and then what else can be done, the design teams can contribute to and help that make that transition further smoother. And Brad, I'd be really interested to hear kind of your side of that, of, okay, well, you're living through it, the woulda, shoulda, coulda kind of things. If I had this, it would make it so much easier. I don't know, is there some thoughts that you may have?
I think you highlighted the issue of a system versus an industry. I have a lot of hospitals in an industry that come up with their own personal solutions. But in reality, if we had a true system, some hospitals are going to close on this type of event. Others will stay open. How do we work together to shift patients as we need to ahead of time instead of waiting until later? There's existing hospitals we are never going to fortify and strengthen to withstand some of the future storms. But there's new hospitals that are being built that could easily accommodate that, with, under current codes. I mean, so it's just but we don't work as a system. And I go back to the community. To me, what this pandemic showed was that we don't work together as a community. I watched a lot of communities just put their hands in their pockets and look at the hospitals and say, well, you know, you got to take on more patients. And it's the community health department's job to step up and help tie these together. They don't all, you know, we don't have to be friends. We can be competitors during the week, but when something happens, we need to be able to come together and work as a team. And I think it'd be interesting to see how that would fit in the design context. As you start with somebody with a new facility, do you have a responsibility to help talk to the others in your system, and what is your resiliency requirement based on their plans and local threats? On the other hand, if you're just renovating an old facility, maybe you can't do enough to make that facility as resilient as it needs to be. And so it's going to be able to accommodate this level of disaster, but not that one.
I think this idea of prevention being better than cure is a fundamental resilience question. If health systems or the health industry was more attuned to the health of their population rather than their sickness of their population, that would be a more resilient population. And I think sometimes we get seduced into the idea of, you know, come to our magic palace of healing. It would be better if the healing happened out in the community, and that we save the magic palace for the worst of the worst cases. And right now, chronic disease is where virtually all of the money in our healthcare system is going. And that is a population health process. It's not what we do inside an acute care facility, but the health system would be attuned to pushing that care into the community and making the community more resilient. And it's a social justice thing. Environmental justice tells us that the least among us are the most profoundly affected by what happens in the environment. And our health systems need to acknowledge and focus on the social justice aspect as much as they think about the resilience of keeping this magic palace of healing going when the big storm comes. If the population, if the community itself was more resilient from a healthcare standpoint, there wouldn't be as much demand on the magic palace.
Yeah, that in a recent deep dive that we did, you know, looking at technology and just healthcare trends, you see that the American Hospital Associations, they publish a statistical report every year, and only 5% of you know, healthcare is actually inpatient, right? So most of it, just like Kim is saying, really is, you know, being conducted more in a community-based setting. So, you know, what does that mean? So that for design teams, are you designing? You're designing for both that 5% and that 95%, like you said. You know, the acuity is increasing exponentially in the hospital, you know, in the inpatient setting, but then, you know, more and more it is being done in the community-based setting. So what does that look like, you know, and how can you be, you know, more preventative, you know, adjusting, is there a food desert need, you know, in the community that, you know, you're trying to serve? What are the behavioral health needs, right? You know, I know a lot of systems have mobile health clinics, you know, ways that go out. One of our teams recently designed a healthcare campus in the St. Augustine area, and they really thought about community integration early on. And you know, sometimes it's providing space inside and also on the campus itself for community-based, you know, educational initiatives to try to address, you know, and mitigate the chronic disease needs. So I think there's a lot that, you know, can and should be done.
Mm-hmm. Yeah, great observations, and I think really valuable insight in terms of the role of a collaboration with the community. I know we've got some questions, and I don't want to put anybody on the spot, but if I got some chats that some people have some questions. So if you'd like to ask the panel any questions that you have, please feel free to do so now. Okay, well, I'll read one that's in the chat. This is from Jason Von Menig, who is a colleague of mine here at Fiber. What kind of policies do you feel would improve access for those who are not currently prioritized by health systems that are predominantly geared towards making money or having proof of insurance before full treatment?
That's easy. Expanded Medicaid, expanded Medicare, universal pay system.
Mm.
That's why it's not getting done. If you look at the telehealth numbers during pandemic, they went up.
Mhm.
Guess what? They're dropping off now because Medicare isn't stepping up and covering the cost of a telehealth visit. Very convenient, very effective, proven to work. Saves gasoline because you don't have to drive. Saves job time. Stay home, babysit your kid, whatever you need to do. Lots of reasons to do that. And yet we don't reimburse for it. So I mean, in our system, in our industry, that's how we get compensated through an insurance process. So the way you change that, it's one simple policy: make everybody's health care payable.
Yeah, I think a lot of folks here in Fiber have your exact same opinion, Brad, in terms of operationalizing something that would allow for a little bit more or a lot bit more equity in terms of community health and well-being.
And I think to answer Jason's question, what in the built environment might we be doing to make that easier to access? And I'm really fascinated by some of the work and Brad said as much about what's being done with technology and being able to deliver healthcare at distance. Wearable diagnostics, the ability for people to take their own vitals and be able to upload that information so that healthcare providers can even work from home to do that kind of work. Just it's pushing the boundaries of what we think of the physical environment of the healthcare system. It's becoming much more permeable by the way that technology is allowing us to do that. And there's a system in the upper Midwest, actually the Mountain West, because the distances for their patients are so huge that they're really pushing this out as a way to deliver their care, so that their hospital is actually a hospital without patients in it physically. The building doesn't have any patients in it, but it's full of caregivers. And that's that is turning it on its head of the way we've traditionally delivered care. And I can only think that Moore's law, every 18 months computing power doubles, means that in a very short time, we're going to have holographic diagnostics available to people in their homes. And goes back to another thing that Brad said, the digital divide, the ones that don't have that access are going to be left behind. And as a society, we shouldn't allow that to happen.
Yeah, and our colleague Keith Buster wasn't allowed to join, but he would, at this point, I feel, be really talking about the digital twins, that he and his team have been working with our clients to create, and so going further with what Kim said, how can, we use this concept of digital twins to really gather data, map out, and really move it further beyond, understanding the mechanical systems, and sustainability from sort of the mechanical side, but also looking into the human side through the integration of wearable data biometrics into the digital twin itself, and then expanding that beyond the facility itself and into maybe a human experience campus map, right? To be able to see maybe heat maps within filters of stress, for staff or for patients, and really being able to integrate, right, the most technology or data that we can through the technology to get a better read or understanding of what's going on. I think that's a really exciting place, of growth and change right now.
Yeah, I think we have a question from Dr. Yan Wang, who's also a researcher here at Fiber, that speaks to what you just referenced in terms of, understanding where we are within the healthcare environment, but also what Kim and Brad said in terms of understanding where the community is. And Dr. Wang has done a lot of research on the digital divide and how it impacts human health and well-being. And her question is, what can we do for people that do not have good digital knowledge or even no internet access? Do you have any idea about current practices, either built or policy, to inform these population health risks or prevention knowledge?
Well, I'm reminded of what many of our school districts have done, is push hotspots out into the community, where they give their students Chromebooks, essentially thin clients that don't have a whole lot of computing power themselves, but they are the window, the door into that digital universe. And those are extremely affordable things that I think health systems could easily see the payback for in improving population health and reducing their costs to provide that application and access to people who don't have it on the other side of the digital divide. I think communities need to start thinking about internet access in the same way that they think about water, sewer, and power. That this is such a profoundly important part of our society going forward, to make the kind of steps that we want in improvement, that simply becomes part of the social contract of being in a community. You get water, you get sewer, you get power, you get internet access. And the more people that have it, the higher the internet literacy will climb. And quite frankly, the digital natives that are born into a internet capable world pick it up like they pick up a language.
Some of our, we've had some great collaborative research relationships with the VA and Steelcase Health, and Steelcase has actually created these telemedicine pods, and they've partnered with VFWs in the different communities. And so that's, an older population that maybe doesn't, maybe they either don't have the Wi-Fi access, or maybe they don't understand how to participate in the telemedicine. So these pods are able to be put together actually in the VFW, and they have a door, so there's privacy, and the veteran goes in with their family member. There's a large flat screen TV. It's really geared towards I think the question was sort of wondering about these populations who maybe either can't access or don't fully understand and how that works. So it has been exciting to see how some of the furniture manufacturers have stepped up and sort of partnered with other organizations to provide that care.
And perhaps communities could place those at City Hall, gas stations, convenience stores, grocery stores.
Yeah, absolutely. Airports.
Still have to have a doctor on the other end.
Yeah.
Well, that actually brings me to another question. I'm sorry, I skipped over this one from Ray Wong related to understanding that we've got a system that's in a big state of flux, and there's a clear opportunity for improvement, and things like improving digital access, being responsive to emerging crisis Ray's question is that he's interested to hear, especially Lisa's perspective on the role of the built environment, of the built infrastructure, in fostering an adaptive workforce that's adaptive to either improvements in digital access or improvements in emerging crises, and adaptive leaders, especially in times of crises.
Yeah, I mean hey Ray, I see your picture there, high five. Yeah, I think that's fascinating. So what can design teams do to really address needs, I would say needs of staff, right? So I know from our clients, we heard during the pandemic, I mean, clinician burnout has been an issue for a very long time. It's nothing new, but it just increased dramatically during the pandemic, especially for nursing staff, because they were not only providing care, they're not only chronically understaffed, but then now they're providing care, and their family members weren't allowed to be there with the patient, so they're providing the role of family member, bringing iPads to the bedside so that they could communicate with their families. And just, I mean, it really, just hearing their stories is just incredible, and so how can the built environment really work to address the needs of the staff, going further into what is respite, what is a restorative break, what's the culture within the healthcare system that it might support the needs for that. And it's meeting the basic needs of nutrition even, and in times of the pandemic when staff was not leaving healthcare systems, there was great articles about hospitals that converted certain areas to sort of more of a grocery store, right, where staff could really get things that they needed even from home before they left the hospital to go home. But really looking in, as design teams are going above and beyond sort of what the code says, or even what the disaster recovery plan says, and diving deeper into that human experience and understanding that narrative aspect that I know a lot of your colleagues, Lisa, really are experts in gathering that feedback directly from the community. And then, because you can't just always throw a Fitbit on it and, like we were talking about earlier, these magic tech solutions, if it doesn't fit the true need, it's sort of this this thing that really is a false promise, right? So that would really be what I would say as healthcare designers, really diving into those needs to really benefit the human experience, and then aligning it with the research and the tech that then best supports. Yeah.
So we're almost at time. We have other questions that I'll go ahead and email the panelists if you have interest in answering them after the call. That would be great. I do want to end this with one question that is, I'd love to hear from each one of the panelists on this. And that is, what do you see as one of the most single significant issues that needs to be addressed in health infrastructure resilience? And I think I might know the answer to part of this, that's not occurring at its fullest right now.
I'll say trust.
Mm.
I think our health infrastructure is built on the 3 pillars of clean water, antibiotics, and vaccines.
Mm.
Without those, you don't have enough hospital beds to take care of everything. Done.
Do you see a way to moderate that, or is that a more complicated answer?
That's probably more complicated in a different forum.
Okay.
But the point is, I mean, here's where behavior affects the built environment. There's not enough money to build enough hospital beds to make everything resilient enough if we can't get the population, our chronic diseases and exposure to these pathogens solved.
Mm. Well said.
I think the industry needs to decarbonize.
Mm.
This is an extremely carbon intensive industry. And it goes back to what I was saying before, first do no harm. The amount of fossilized carbon that this industry puts into our atmosphere every minute dwarfs imagination. And it doesn't have to be that way. And if we don't start doing it and doing it very seriously, very soon, resilience is going to become such a profound issue. And an ounce of prevention is worth a pound of cure.
Well said. Lauren?
Yeah, from my perspective, I would say it's having a holistic approach to addressing whatever the future may hold. And it could be very complicated, and making sure that we're making the decisions that we are with as much information as we possibly can have, based on science, based on best practices, to be as prepared as we can be, and understanding how critical our health infrastructure is in every aspect. You know, as this conversation has evolved today, you know, we're touching every person's life in some capacity, and that is, you know, requires us to bring as many perspectives as we can to the table, from each type of population and background. So, and then you can have that holistic view. You can have the life cycle, thinking through longer term, have those life cycle assessments that you do in order to identify those hazards, and then take measures to address them.
Lisa, you want to close us up?
Yeah, so I'll say my thing, and then I'm going to hop off like a genie to the next call. But you know, I would say really one of the biggest things right now is finding better ways to integrate the technology, the sensors, the AI. You know, it's this giant. We're just at the tip of the iceberg, and so understanding how to do that, how to do it well and meaningfully within the built environment, to better understand how design is truly impacting, you know, the humans within the space. I think that is really a huge need right now.
Great. Well, I want to thank each one of our panel members today. This has been very rewarding, a great conversation. This recording will be posted on the DCP website or YouTube site. Again, if you have any questions, most of you know how to get in touch with me. Please feel free to send them on, and I will respond. I will send them on to our panelists. Thank you all again so much for joining us today.
Bye.
Bye-bye.